I know that you've had a very long day, and we've still got a lot of program left, so I'm not going to keep these next two talks too long, because I think it's the least controversial of subjects that you're going to have to hear today. So I can be far more didactic, but hopefully there are one or two learning points from each of the sessions that you should be able to take away. I'm not certain I earned my place as co-director. I'm not in the same league as Gianluigi or the last presenter, but I think by virtue of the fact that I'm here in London, I'm allowed to speak once or twice at the ISWOG meetings. But it's always a pleasure to do so. We're going to start off with cystic or echogenic fetal lung lesions. Because this is meant to be a little bit advanced, I think the diagnosis aspect we can keep relatively short. I think we all recognize this aspect of fetal anatomy when it goes wrong. It's fairly obvious to everybody when we see an echogenic lung lesion when we're scanning. This is a typical appearance, and on the right we have a CT appearance of the fetal lung lesion. You can see here that there's mediastinal shift with the heart, which is typically over here, moved over to the right, and a clear white demarking region there. When we see these lesions, there are three main categories. In fact, the first two are the ones that we usually concentrate on, typically named cystic ambulatory malformations, or CAMs, and pulmonary sequestrations, which are also called extralobar sequestrations, so the same. There is a much rarer problem, congenital high airways obstruction, or chaos as it's called, which we'll also touch upon because it is one of the rarer differentials for this problem. If we stick to CAMs in the first instance, and these are pathological definitions, okay? So I'm talking about in the anatomy lab. There are classically or traditionally three types. There's the macrocystic type on the left-hand side, or type 1 if you want, but macrocystic says what it is. There's a microcystic CAM, which is very similar to the polycystic kidney, which is these cysts are so small that you will not see cysts. You will see a whiteout of the lung like we did before, and these sort of mixed varieties. So far, simple. It's very important for us to realize that CAMs are usually unilateral. Greater than 95% of CAMs are unilateral. It is relatively rare to see bilateral echogenic lung lesions, and when you do so, that is when the diagnosis of chaos should be borne in mind. Here's the whole spectrum of CAM. So here, for example, is the macrocystic variety. Everyone can see the cysts here, and again, mediastinal shift of the heart. And this is the laboratory specimen showing these lesions. These are not destructive lesions, they are space-occupying lesions. So the remainder of the lung tissue, which is not developed in an abnormal way, it remains entirely normal. The developmental abnormality here is that the millions of alveoli that form this part of the lung do not connect to the bronchial tree. If they do not connect to the bronchial tree, then the fluid production of these alveoli accumulate to form cysts. If millions of alveoli are cystic, then you get the microcystic variety, which is a whiteout, but every now and then you will have a dominant cystic appearance where you will get a larger cyst. So most of the lung tissue around here is entirely normal, but this is a large piece of lung. The differential diagnosis is pulmonary sequestration. Typically, neonatally diagnosed because of the presence of a pleural effusion, and here again you can see a pleural effusion is associated with this highly echogenic piece of lung. Clinically, when you scan, everyone has a kind of distinct, tries to make a distinction between CAM and pulmonary sequestration. The distinction being, you see this and you say, okay, I need to see if there is a separate arterial supply, because the distinction is that both CAM and pulmonary sequestrations do not connect to the bronchial tree. The distinction, however, is that pulmonary sequestrations have their own independent blood supply that does not come from the pulmonary artery. Typically, the supply comes directly from the aorta, either above or below the diaphragm. So if you look at this particular CAM, you can see that the pulmonary artery is supplying this CAM, and that the aorta does not have any independent supply. Is that clear? Yeah. So we have an independent blood supply. So pulmonary sequestration here, not connected to the bronchial tree, and has an independent arterial supply coming directly from the aorta. At this point, we need to digress a little bit. These distinctions, these pathological distinctions of pulmonary sequestration and CCAM are totally histological and pathological, and they're not clinical. Most recent studies have shown that these echogenic lung lesions are usually of mixed typing. That means that when you take them out and put them in the laboratory, a significant element will be CCAM-based, and a significant element will be pulmonary sequestration-based with an independent supply. The majority of the time, these echogenic lung lesions are CCAM-heavy and pulmonary sequestration light. So only small components are supplied by very small arteries that you will not see on ultrasound. And that's the main reason we have turned to going away from a prenatal diagnosis of CCAM or a prenatal diagnosis of pulmonary sequestration and typifying these lesions as echogenic lung lesions. Try not to be specific as to whether it's a CCAM or a pulmonary sequestration. If you see an independent blood supply, say this is an echogenic lung lesion with a significant pulmonary sequestration component. If you see an echogenic lung lesion with very large cysts in it, then this is an echogenic lung lesion with a predominantly CCAM component. Does that make sense? Absolutely. So here again you can see to the echogenic lung lesion, can you see a direct arterial and venous return to this echogenic lung lesion coming from the descending aorta? Yeah? The distinction being that these are pulmonary arteries and pulmonary veins that supply this echogenic lesion, which is mainly a CCAM component. Pulmonary sequestrations can also be subdiaphragmatic, as in this case. Here you can see a subdiaphragmatic CCAM, pulmonary sequestration. Do not confuse subdiaphragmatic with extralobar and intralobar. This, again, is a histological distinction. So when we see it and when we scan the baby, we cannot distinguish intralobar from extralobar easily. The way we will distinguish that is by default. All this means, extralobar, intralobar, is whether this lesion is encased in a pleural membrane. If it's an extralobar sequestration, it does not have pleural membranes over it, and it is more prone to torsion. And that leads to two things. Extralobar CCAMs, or extralobar sequestrations, are more prone to torsion and more prone to developing pleural effusions, and also more prone to spontaneous regression, because as it torts, the blood supply becomes constricted, and you will see a lesion which then disappears. So this is a histological distinction that we cannot make antenatally. You can infer the fact that it is extralobar by the finding of pleural effusion, and you may suspect it if you see antenatally a rapidly disappearing lesion. Finally, we come to congenital high airways obstruction, which is either a consequence of tracheal aplasia, agenesis, or laryngeal stenosis here. The fact that the upper airway is obstructed leads to grossly distended lungs, which look very similar to a CCAM. The difference being that these lungs are hugely distended, the diaphragms are flattened, and the heart is maximally compressed in the middle. The compression of the heart leads to ascites and hydrops and heart failure, and pathologically speaking, these lungs have huge great rib markings after delivery. Antenatally, this little sliver here is the heart, which is entirely midline and squashed between two hugely distended lungs. And there are these bronchograms showing the distended airways going down, which can be seen over here. Andrew, my pointer's dying. If you can get me another one, thanks. That are shown here. These are the airways again, fluid-filled airways that are seen distinctly within the highly echogenic lungs. When we come to the way to make a differential diagnosis, here's a simple algorithm which is fairly easy to follow. If you have chest tumors that are lateral, you see chest tumors that are echogenic with a flattened diaphragm, then microcystic, macrocystic are predominantly CCAMs. If they're always bilateral, dilated airways, hydrops and ascites, you're talking about chaos syndrome. If there's a distinct arterial supply from the aorta, then it's predominantly a pulmonary sequestration, and the differential with the stomach and liver and the chest is a CDH, as you heard from the last lecture. If it's unilateral with normal doming of the diaphragm, then you need to consider temporary bronchial obstruction. Thank you. Temporal bronchial obstruction as a possible cause. And these are the ones that disappear very quickly. So you scan one day, and the lung looks a little bit brighter, and you're worried that it may be a CCAM or a pulmonary sequestration. The clues to how important it is if the diaphragm is not domed. And if you see a couple of weeks later and it's disappeared so quickly, then it's got to be a sort of temporary bronchial obstruction. Midline echogenic echoes are far rarer, and typically we're dealing with sort of enteric bronchogenic cysts or teratomas, and these are rare diagnoses. This is the more important aspect. We're going to talk about the natural history and the management of echogenic lung lesions. It's very important. We'll start with chaos, which is by far the simplest. Expected management, as you would understand, is entirely poor, either because of fetal death due to hydrops and heart failure or delivery, and the very difficult resuscitation of a very sick neonate which has got no airway and needs an emergency tracheostomy. Postnatal management, babies that have been managed by a planned exit procedure, amazingly have been reported to have a 90% survival. That's 10 cases in the world with 9 survivors. Now, you must be aware that this must have a certain amount of reporter bias. I'm sure that there are many other cases that have been delivered which haven't survived, but the 10 that have been published reported a 90% survival. So on the current evidence, it may be appropriate, should you come across the rare diagnosis of chaos, to at least consider referral to a center that has experience in a fairly invasive procedure of undertaking an exit, a fairly high-risk procedure for the mother. Fetal treatments are uniformly poor. There are only 3 reported cases currently, of which 1 died, 1 has severe physical and neurological handicap, and the 3rd is significantly physically handicapped, but is luckily neurologically normal. I think that fetal treatment in terms of hysterotomy, laparotomy, etc., exteriorization is not to be recommended. If we talk about the natural history of echogenic lesions, everyone here is familiar with this appearance, okay? I'm sure if you've diagnosed it, you see antenatally an echogenic lesion, you see the heart, you see this huge great thing, and then the baby's born, and your neonate says it's gone. Is that familiar here for most people? No? Yes. And then you say, okay, it's resolved, and then you send the baby home? No? What do? It's gone, right? Send the baby home. Okay, good, excellent. That's certainly folklore. And that's certainly reported. Most people will see it, and if you scan antenatally, typically you will see the resolution. As you scan them serially, you will see this lesion disappear. By the time the woman gets to the 3rd trimester, you will almost certainly not be able to see it. And fetally, resolution is reported in 50% of cases, and neonatal X-rays have also reported 50% of resolution, and those are taken from those 2 papers. Unfortunately, these are the 2 largest series available at the moment. Out of 74 neonates in this series, despite having normal X-rays in 50% of cases, CT scan identified the CCAM mass in 73 out of 74 cases. In our case series, one of them wasn't, strictly speaking, identified on a CT scan, but the baby was sent home because of a normal chest X-ray, and then developed severe lung infection and died before it got back. And the post-mortem revealed the CCAM, which was not evident on the X-ray. So it's absolutely vital. If you've seen it prenatally and it has persisted for more than 2 or 4 weeks, then it is an echogenic lung lesion of CCAM or pulmonary sequestration origin. And in our cohort, we had, because we looked at a historical cohort, we had to chase up 20 babies that had been sent home with a normal X-ray saying it's all resolved, you're all fine, you're gone, in order that the respiratory physicians and the respiratory pediatricians could then do appropriate follow-up for these babies. So we had to chase our historical cohort and say, you were sent home inappropriately. So I think it's very important now that you consider routine neonatal scan. And our regional protocol in the south of England is that these babies, despite being normal at delivery, which they almost always are, will have an elective CT scan to identify the tumour and to then make a decision as to what is the best course of management. Is it expectant? Is it radiological intervention to embolize the tumour? Or is it open surgery? Outcome of CCAM. In the absence of hydrops, greater than 95% survival. And this is from a review done recently, and it's published, and it should be... Gianluigi, have they all got CDs and DVDs? Yes? Okay, well, you should have the publication should be on your DVDs. In the absence of hydrops, out of a large case series, greater than 95% survival. And that is our individual experiences with these cases as well. However, CCAM with hydrops, unfortunately, has a very high mortality. You'll be pleased to see that less than 5%, usually 5% or less, will have hydrops. And that only should occur in these unusual tumours which are bilateral and large. Yes? The mechanism of hydrops is a bilateral lung lesion which is causing cardiac compression and hydrops. Or, very rarely, in a pulmonary sequestration which has got such a high blood flow that it's causing an AV malformation, an AV bypass, and the baby's going into hyperdynamic heart failure. So expectant management here has a very good survival. In the presence of hydrops, unfortunately, the vast majority of case series have a very poor survival, 95% mortality. Again, very similar to chaos. However, here you have the main brunt. Shunting for cases of echogenic lung lesions where there are macrocystic involvement has been reported to have a 65% survival. Now, this is a peculiar series. Fetal surgery is a conglomeration. Fetal surgery here in this series involves cases that were treated by open fetal surgery, which were almost universally had a bad outcome, and a smaller case series that were treated with radiofrequency ablation or interstitial laser treatment. And the role for interstitial laser radiofrequency ablation are these echogenic lungs which have a mainly pulmonary sequestration element and where the baby is going into hyperdynamic heart failure and you want to try and reduce the blood flow, or in lesions where it's a unilateral region which hasn't resolved and the baby's going into heart failure because of cardiac compression. I have to say that I am extremely reserved about treatment of a unilateral echogenic lung lesion which is presumed to cause heart failure. I think that is extremely unlikely in the absence of hyperdynamic heart failure. Because what happens, the reason for the so-called apparent resolution is this tumor here at 20 weeks, which seems so big and has pushed his heart across, is only under 2 centimeters in size. It's 2 centimeters or so. And as the baby grows, this tumor does not grow. It stays the same size. And the normal lung grows, as does the cavity of the chest. So what happens is by the time the baby ends up being 3.5 kilograms, this tiny 2 centimeter by 1 centimeter tumor is almost impossible to see in the lung. So the natural history of this condition is that this lump disappears as the pregnancy goes along because all the normal tissue grows during the pregnancy. The additional effect is that as soon as the baby is born, all of the normal lung that surrounds this inflates with the first breath. So there is an additional effect which makes the abnormal piece of lung look even smaller after delivery. So I have to say I've got extreme reservations even about interstitial laser and radiofrequency ablation unless it is in this peculiar group where the echogenic lung lesion is causing hyperdynamic heart failure. So, in conclusion, echogenic lung masses, outcome is good in the absence of hydrops. Intrauterine amelioration appears to be frequent, but tumours rarely regress, and surgery is often necessary postnatally. It's important to realize that large tumours where open fetal surgery is necessary runs a risk of scoliosis. Thank you.